So it's a pleasure to be here, and I want to thank the organizers for giving me the chance to visit CHOP. And I was a student at the University of Pennsylvania a few years ago, and my son was a student at the University of Pennsylvania not so many years ago. And it's always really a breath of fresh air just to walk across the campus and see the liveliness. And this place is, it wasn't even here when I was here, and it's quite amazing what you all have done, so congratulations. So I made a decision not to talk about omics. There's a lot of wonderful talks this morning and for the rest of the day, and it is certainly the driving force for a lot of what we call precision medicine, or what we used to call personalized medicine. And rather, I'm going to talk about a set of methods that would have application to omics data, but also other kinds of data. And I'm really going to sort of stand back and take you can relax. There's nothing technical here that you don't already know. I'm just going to remind you of some things you do know, and maybe you'll enjoy thinking about them for a short while today while we're together. So what motivates this kind of work is that when a patient and a doctor sit together attempting to make a decision that ultimately will have a dramatic effect on that individual's life, it used to be that most of what they talked about was qualitative. And what's happened because of the twin revolutions in biology and in information technologies, there are now relevant and complex data that have to be brought into a discussion if that discussion were to be scientific. And the data look like this, right? And what we've been doing up till now in medicine is trying to take complex things like what are up on the screen and turn them into categories. Oh, you should do this or you should do that. I was just at a meeting yesterday in which it was about the decision of whether to implant a defibrillator or not. That decision is made, I think, about 100,000 times per year in the United States each year. And the costs of deciding to implant the defibrillator is $40,000, $50,000 plus all the other things that happen down the road. And so imagine that moment. What's typically done at that moment is we have data on ejection fraction, and if that number is less than 35%, we implant it, and if it's greater than 35%, we don't. And this talk was about the other kinds of data that are available now if you do a fMRI imaging study of the heart. And in fact, this person had constructed numerically constructed a heart and actually could show how the arrhythmias would occur and how they would propagate and predict whether, if there was an insult to the heart, it would turn into a significant arrhythmia that could be life-threatening, which would be the kind of data that you could then bring to that decision, except it was very complicated. It was a movie, basically, and there was an effort to take the movie and to dichotomize it the way ejection fraction had previously been dichotomized. My point is that the data are rich enough now that these simple sorts of rules, like do this or do that if that number is bigger than that cutoff, really isn't the best way to use the evidence. So I want to talk to you today about how we're going to be using that evidence, whether it be genomic or images or other sorts of things. And what I'm going to tell you is something that we've already known for a long time, and this is a quote from one of the fathers of medicine at the University of Pennsylvania, William Osler, who I think was here in 18-something, and you can read it. That's what he said. Variability is the law of life. No two faces are the same, so no two individuals react alike and behave alike under the abnormal conditions of disease. So this was his observations of working with individual patients. He could never have imagined that the things that make people different would be available to us, many of them, as novel measurements in this era in which we live. So now what I want to do is talk about how to use that information that's emerging to improve patient care. So in order for us to talk about this together, you have to put on your clinician's hat. Are there any clinicians? Raise your hand if you actually treat patients. Not if you're an MD, I know you're all these, but if you actually treat patients, raise your hand. Okay, well there's some people who treat patients. So this is sort of what it's like to treat patients. You have to every day make decisions, right? And so And what happens when you make a decision is you sit down with the patient, or you speak to them on the telephone, or you speak to a loved one, and you have data that's about that patient. So here's an example. You have data that this is a 40-year-old man. Fact one. Fact two, no family history of this particular disease that we're interested in. Fact three, they just screened as positive for that life-threatening disease, and now they're sitting in your office. When I say just screened, they actually did the screening test because they turned 40 3 weeks ago, and they tested positive. They don't really know what that means, but they're worried. This man's wife is very worried. He's got young children. It took him 3 weeks to get into your office. That took us too long. There's a lot of angst around this, and now he's sitting across from you, and you have to do what? You have to use the data and answer some questions. And the first question this man has is, doctor, do I have that life-threatening disease? And then, what should I do? Yeah? So that's the sort of situation. So what's the problem? It's data about a patient, and then the question from the patient about the state of health. Yeah? So what does the doctor do? Well, if you're not a doctor, what would you do? What would you do? Ask more questions. Yeah. It's like at the end of the research paper, further research is needed at the end of the grant. Exactly. Well, that's a good recommendation. Okay? But the first, before you, in order to know whether you needed more data, the first thing you would do is you'd remember what they told you in medical school about this particular test, right? And in fact, what you would like to do is you'd like to refer this clinical decision against a population of similar decisions where we knew something about the outcome. Right? So here's a table of 10,000 previous decisions, right? And this just shows the true disease status in the columns and the test result in the rows, and let's focus on the subpopulation that actually, like this man, had a positive test. These people, by the way, are all around 40 and no family history. Yeah? And there's the data about this man. Of 10,000 people, fully 1,000 of them would test positive with this test you told him to go get because he had turned 40, and only 15 of those 1,000 actually have the disease. Yeah? So here's some information, some evidence that would have been great for this man to have had 3 weeks ago, but once you show him this table, he feels a lot better, and he does a quick calculation. If it were me doing it, I would say it was 0.15%, but I actually did it again just a minute ago, and it's 1.5%, because I'm a statistician, and I sometimes get it a little bit wrong. So 1.5%, and so that's his what? Positive predictive value. It's the chance he actually has the disease. And how do we get that number? We reference the individual with a certain set of data against a population of otherwise similar individuals for whom we know the result. And so what I'm trying to point out to you, something you probably already do, that really clinical medicine is about referencing individual patients against populations of patients about whom we have more information in order to try to estimate what the person's situation is. And so really the rest of this talk is about doing that, right? And so, in fact, what we have as an opportunity today, all of us, is to be able to create an analog of the computation we just made, this referencing of an individual to an otherwise similar group of people about whom we know more. We have the opportunity to do that when the data that we have aren't just 40-year-old, no family history, positive test. That's a binary test result, right? When the data are the kinds of things that I have on the screen to begin with. So, said another way, if we're going to use those data that we're generating in all of our research laboratories, right? If we're going to use them to benefit patients, we have to somehow learn how to take populations of those data and leverage them to make better decisions for individual patients. We have to reference the patient against the population. And secondly, I showed you what the rates were for a 40-year-old, no family history with a positive test. But wouldn't it have been great if we also had maybe some genetic predisposition, and we would have compared him not to that generic table, but to a table that was subsetted to be more like his situation, right? We want to make these tables as narrowly defined as possible so that the words otherwise similar are actually closer to his situation. And that's really the aspiration of so-called precision medicine, precision medicine is to do this referencing of the individual against the population with ever more narrowly defined, more precisely defined populations. And does anybody object to anything I've said thus far? Because otherwise we should stop and adjust. No? Okay. So, now, I thought it would be useful to put up one slide to talk about what we do in some area of life where we get it right just about every single time. That's landing airplanes. Right? Now, I'm about to go on a trip to Africa, and I always, whenever I get a trip coming up, I always go get this slide because I do worry about, like, airplanes not landing properly. And sometimes, and so this just is to remind me that they get it right like 99.999% of the time. Wouldn't it be great if medicine was like air travel in that a person's life takes off and they fly around and then they land safely at the end of the trip, just about every single time, right? And so let's think about how it works for an airplane to see what we want to try to emulate. So this is kind of pointer, isn't it? Just so, oh, there. Okay, yeah. So this is a picture of actually BWI Airport, the one that's near my house. And there's the Chesapeake Bay. We're up here someplace now, and here's Baltimore. And there's several radar stations in the vicinity, and these black dots are the radar readings of where the airplane is as it's approaching BWI. And most planes do come in from the sort of south or southwest. They go up around, and this is when the winds are from the west. They land going towards the west. Yeah. So this is the flight, and you can see the radar. They don't know exactly where the airplane is. I know that's true because if you ride in an airplane, the trip is not like where those black dots are, right? So it would be too unsettling if the plane was like that. The radar has error, yeah? And so what do? We use something called the Kalman filter. The engineers have developed something called the Kalman filter, and they take these multiple radar readings and they smooth them out. That's the red crosses, right? And in fact, I have the true curve here, which is the blue curve. And you can see the red crosses are much better estimates of the actual airplane trajectory than the raw data. So they smooth the data. And then in airplanes, at certain moments, like up here, there's an air traffic controller, think doctor, right? And the doctor gives a command to the pilot, and unlike patients, the pilot follows the commands of the air traffic controller and then descends and lands safely just about every time, right? So what was done in this case? Well, we made imperfect measurements of the state of the airplane. We smoothed out those imperfect measurements. We made decisions about how to get from where we were to where we wanted to be, executed on those decisions, and landed safely. Yeah? Okay. So my question for you, before I go on, is what's different between landing a human being safely at the end of their life and landing an airplane safely at an airport? What are the fundamental differences in the systems that we're comparing? Anybody have any ideas? Yes? Each human being is different. So each airplane, they're different, but they're not that different, right? Exactly. So airplanes are more like each other than people are like each other. Great. What else?
Equipment replacement is more expensive.
In the humans or the airplanes? in the very well said. Okay. What else? Go to the information science part of this. Yeah.
You can fix it as deviation. It's
Easier to fix. So that was the system is more easily controlled. You have more control. What are the controls? Well, first, before I go to the controls, how about the state space of the system? There's those engineers here. What's the state space for the airplane?
Much smaller than
X, Y, Z, and T, right? If you have X, Y, Z, and T, you know the state of the airplane. Or if you prefer, you have the position, the velocity, the acceleration. Then you have the whole system. Yeah. And what are the controls for an airplane? There's a handle here, yeah? Right? And then there's a couple of flaps you can move. And what do we know about the influences of those controls on the airplane? Well, we have the Navier-Stokes equations. We have the whole physics of the system available to us, right? Which means that in the controls, we know that if we hit the throttle a certain amount, given the state of the airplane, right, we know exactly what's going to happen. We can predict what's going to happen. There are some uncertainties like the turbulence and so forth, but basically we know what happens. How about, what's the state space for a human being? Oh my God. You can't even begin to answer that question. Yeah? So we don't even know what the state variables are. And we certainly don't have anything that's like the Navier-Stokes equations, right? Or the laws of physics, right? We have no laws, almost no laws of biomedicine that are analogous to what exists for an airplane. And so that leads me to a point, which is that when you think about individualized health, what we call individualized health, personalized medicine or precision medicine, you're really operating along a continuum between what I would call mechanism, where airplanes live, and empiricism, where most of medicine lives. Most of the talks we've heard today were about our ever-expanding effort to move on this continuum away from empiricism towards mechanism. We're trying to understand the mechanics of the diseases that we study in such a way that we would be able to intervene on them with interventions that we know will produce the outcome that we seek. And there are some examples, some famous examples in medicine where we have done this. I have a colleague who studied color blindness, and in his research, they know the genes which cause color blindness, and they know the proteins that those genes encode. There are only a couple, and they know that when there's a particular, if you tell me which base pairs are mutated, they know how the protein will fold, the protein in the back of the eye will fold differently, and they know whether you'll be colorblind. They can tell you exactly because the physics is worked out. The chemistry and the physics is worked out. There's some other examples like that. Gleevec was an example of a treatment that was designed for a known mechanism that actually works if you're one of the people who has that situation. But unfortunately, we thought when we did the Human Genome Project that as soon as we got the sequence, it would just all flop out. The equations of the system would be clear, and we would then be in a new world. Right? And we're moving in that direction. We're moving from right to left. But we had a little study at our place of experts. We asked them what fraction of medicine is empirically based and what fraction is mechanistically based. Yeah, everything's a little of both, but in other words, how many times can you go into the FDA, and say, here's a new treatment, I'm not going to do a clinical trial because I know what's going to happen, right? We don't do that. It's because we're still largely empirical. And in fact, if you look at where money is spent in medicine, it's probably 99% spent at this end, where we really can only be empirical, not mechanistic. Okay, so that leads me to statistics. Because if it's empirical, what we have to do is we have to, going back to that situation of trying to take a population of relevant data and apply it to a decision for an individual, we have to have a model to do that. So that's what I want to talk to you about for the next 6 minutes. Any complaints or concerns? All right, great. So let me just focus on these first 3 questions. So what decisions do doctors have to make with their patients? Well, the first decision, I think, is what's my health state? Where am I? In that airplane model, where are we, doctor? Well, we're close to Baltimore, right? Second is, where are we headed? Where am I headed? What's my trajectory in this disease? Am I getting better? Am I getting worse? What can I expect in the future? And then, the big question, the hard question is, given the available options, what's the right thing for me to do today to move my trajectory in the direction that I prefer? Those questions actually are also very closely related to questions that systems people want to answer, public health people want to answer about the population. But let me just stick with the clinical questions today. Okay, so I'm working you too hard. It's time for a break. So here's a picture. This picture is entitled Platos Cave. And so I need you to look at it just for a second. I love this picture because it's sort of hard to see what the hell's going to happen in the picture. You have to look at it for a while. How many people already know this picture? They've looked at it before. Yeah, it's quite famous. And so someone who either has thought about it or now is having this amazing realization looking at it for the first time. What is it about? What's this picture about? Yeah. A point of view. So which point of view are you thinking about?
Poor guy.
The guy is chained to a wall.
It
Right?
looks like he's got monsters.
So where's the doctor or the patient in this picture? The guy is chained to the wall, right? Exactly. And where's the data, the measurements, the 40-year-old man, no family history, positive test? Where's that depicted? The shadows on the wall. In what sense are they shadows? They aren't the reality, are they? That patient comes to you to ask you, what is my health state, doctor? Because the health state is not the test result. That's not a test. That's not a health state. That's a test result. So it's the imperfect image of reality as seen by the patient and doctor here. Changed to be able to only look at the wall, to not be able to see what really is true, which are these little animals here being carried by these goblins not below, right? And then the reflection is this fire burning in the cave, causing the shadow. Are you with me? So this is our lot in life. If you want to answer the questions that I just put up there, what is my health state? What is my trajectory? You don't get to see them in most medical problems. You only get to see the imperfect reflections of them onto the wall. Yeah? Okay, so now that was, the reason I showed that picture is because Plato was what? He was Italian, Pakistani, what was Plato? Greek, exactly. So I'm going to use Greek letters now. You see Greek letters in honor of Plato. So these are the unknown health states changing through time. I'm going to show you a model, and it's going to be a network model, and we're going to see that we can answer the questions we want to answer. We can actually take the data in a population of people and answer clinical questions if we use this model or something like it. And what I'm really going to leave you with is the notion that we need to be implementing these models in the practice of medicine, especially to get ready for that moment when the data gets more complex that good clinicians can hold in their brain and make sensible decisions. And I'll show you some examples. Okay, so this is just the true airplane trajectory or the true health trajectory for an individual, and I is the person, T is time. Okay? And I've put down here another Greek thing. If it's Greek, we don't observe it. It's in reference to Plato. It's the thing that's giving the shadow, not the shadow. Right? And so then there's this other characteristic which we might want to know, which is just a summary of the trajectory. Maybe this delta indicates whether the patient's stable or getting worse. Right? It's just be an indicator, a functional of the underlying health state. Yeah. And the health state might be, like in the case of an airplane, a multivariable thing. It may take many variables to describe it, but nevertheless you get the idea. Okay. So now what do we do in medicine? We have treatments, right? And we want to give a treatment to a person that changes their health state. We don't give the treatment to change the measurement. We give the treatment to change the health state, which we hope then will be reflected in the measurement. Yeah? So the treatments are here, and for an individual, we're going to quantify this. These R's are just an indication of whether you got the treatment or not, and the beta tells us what happened. Did the treatment change the trajectory? So most of the questions that I put up on the board are what is the health state, what's eta, but also what's the effect of the treatment, what's beta. And notice I've called this beta, so I being a person, because I'm going to contend that most treatments don't work the same for everybody, and so we should be trying to estimate what a person's benefit is, not just the average population benefit. Okay? And then there's some other factors. These are just like your age and stuff like that. Don't worry about that. And then what happens is you don't get to see the true animals being paraded behind the wall. You get to see imprecise shadows of those measurements in your data. Yeah. And what's exciting about medicine right now, and what precision medicine is attempting to make these observations more like the underlying state variables than they have been in the past. They actually measure the fundamental processes that our treatments are attacking. But in the meantime, we better be acknowledging that we don't have what we need. We have imperfect measures. Okay, and then the last thing that's interesting about medicine is that the decision about whether to give a treatment at this time, how do we make that decision? Do we do what we'd like to do, which is to say, what's the health state, what's his trajectory? Oh, we better give a new treatment because it's not going the way we want. Well, we can't because we don't observe the health state. What do we do instead? We take the measurements of that health state and we make a decision about the treatment based upon not the true health state, but the measured health state. This is a problem in engineering. If you've ever flown an airplane, if you have an imperfect measure of your flaps, right, and you correct the measurement of the flaps, not the actual position of the flaps, you can get into some wild, exciting rockets. So that's a bad situation, and it is the one that we're confronted with. There is one positive thing about this situation in that the difference between Y and eta is often just noise, random noise. And so there is a sort of randomization going on in choosing which treatment to give based upon previous observations. And that enables us to learn from the data in a way that we wouldn't if it was eta that was causing the effect. Okay, so there's a patient, one patient, that's the model. You with me? Okay, now I said I was going to refer the patient to a population, so I put that kind of red box and put it up there, and then put many patients, right, in the population. And then I recognize that things of interest are connected. So here's the effect of a treatment on Joe, right? And here's the effect of the same treatment on Karen. And here's the effect on another person. So I have 1,000 people in my population. So you could imagine that there's a distribution of treatment effects. And what we do in clinical trials is we estimate the average of that distribution. But if you're worried about a particular patient's benefit, you can't just know about the mean. You have to know something about the uncertain, about the variability of the treatment effects across people. So we need to know that as well. And then each of these unknown things in individuals can be brought together into a population, and I won't bore you with it. But anyway, there's a model. Okay? And this is just what's called a network model. And so now that we're going to take a digression. Here's two people. Who are these people? Who's the person on the left? Who's a computer scientist? Babbage? Well, that's a good guess. No, it isn't Babbage. But who is the mathematician on whom Babbage relied in the early days of computing? Who did the mathematics that underpins computing? George Boole, right. Okay, now who's the person on the right, if you didn't look carefully? That's Sir Thomas Bayes. Although I put this picture up about 2 weeks ago in a meeting at the NIH, somebody came up to me afterwards and said, that is not Bayes. That is not Thomas Bayes. That's a picture that's in Wikipedia, which is where I got it, that somebody said was Thomas Bayes, but that is not Thomas Bayes. So I apologize for that mistake. It shows you shouldn't rely on Wikipedia. But anyway, what's happening is this graph can be analyzed now using Bayes' rule. It can't be analyzed using just Boolean logic because there's too much variability in the system. So you got to use Bayes' rule. And what's happening in all of your laboratories, I know, is you're moving from decision support tools, which are if this, then that, do, those kinds of long logics that fill up EPIC. Right? The EPIC is just filled with. You're moving from that, now that EPIC has finally gotten there, to something that's more scientific, more Bayesian. And I only have this picture because I love this Boole Bayes, right? Sorry, that's statistician's joke. All right, okay, so that's the end of the model. Now I'm going to do is in the remaining time, I'm going to show you a few examples where that network model gives you interesting answers for patients. Okay, so here's a study called the PERC study, Pneumonia Etiology Research for Child Health Study. It's a study of 5,000 children with pneumonia in 7 countries around the world and 5,000 matched controls. And this is funded by the Gates Foundation. Pneumonia is the leading cause of child death in the world, with about 1 million deaths per year. And the Gates Foundation is investing its money to try to reduce that mortality. The trouble with the word pneumonia is it's not a mechanistic word. It's just a description of symptoms. And there are about 30 different pathogens, 30 common pathogens that cause pneumonia. So pneumonia is an infection of the lung, but you can be infected with many different things, with a fungus, with a virus, with a bacteria, and bacterium, and which of those you have dictates which treatments are going to be beneficial for you. And more importantly, from the Gates Foundation perspective, which are the more prevalent causes is what determines the kinds of investment they'll make. So if it's largely viruses, they're going to do more vaccines. If it's largely bacteria, they're going to do vaccines or other sorts of antibiotic treatments and so forth. You with me? So we got to know what's the prevalence of each of the causes. So here are the kids we're talking about, and here's the model. It's exactly the one I just showed you. So there's some Platonic truth, the infection in the child's lung, a pathogen who is infecting this particular child that you're about to try to make a decision about how to treat, right? And we do not see that. You cannot go into a child's lung and see what pathogen is there. So what do we do instead? On rare occasions, we stick a needle in his lung and we take a sample, and with some probability we'll actually sample the fluid that has the pathogens, and if we do find a pathogen there, we're like 99.99% certain that is the cause. And so you could say it's like a perfect gold standard measure, but you rarely get this data. What we do for all the children who are cases, the 5,000, is we take a blood sample and we culture the blood, and we look by PCR as well to see if we can find a bacterium there. And then for everybody, both the cases and the controls, we take various samples from the nasal pharyngeal cavity and we look to see by PCR whether there's various things there. Yeah? So that's the data on each child, PCR of the nose and the sputum, of the PCR and culturing of the blood, and with like in 1 in 1,000 kids, or more than that, 3 in 1,000 kids, we get a needle into the lung and we actually see what's there. That's the data. So what can we learn from that data? Well, we use the model I just described. Here's the truth in the lung. Here's all that complicated data. We do know something about the error rates of this data from controlled trials of vaccines, and we're interested to know whether various factors influence what causes children to have pneumonia. So, and we do have that for all the kids. And what are we interested in? We're interested in the population etiology, that is to say the frequency with which each pathogen causes childhood pneumonia. That's the average of all the states for all the different kids. And we're also interested in this one child up here, what is the pathogen in his lung? So all you do is you turn the crank of that model I described for you, and let me just not worry about this, but here are the 11 leading pathogens: RSV-AV, a virus, pneumococcal pneumonia, a rhinovirus, a bunch of others. And here, each of these is assumed to have a similar chance, the exact same chance before we see the data set of being one of the causes. And here are the posterior distributions for the fraction of people, fraction of the 5,000 children who are affected by each of the viruses. So a full quarter of the pneumonia is estimated to be caused by RSV virus. Okay? And a big chunk from pneumococcal infections and so forth. Right? So this is just an analysis of the population rates. This is the data. I'm not going to spend time with that. But you can calculate things like what fraction are viral. So 60-some% are estimated to be viral. And you can see uncertainty from about 50 to 70%. And then what you get for each individual child who has a particular set of measurements. Here's the measurements for this child. They had Haemophilus influenza growing in their nose. They also had RSV growing in their nose. They didn't have, there would be an X over here if they had something in their blood. They had nothing in their blood. 11.6% of children had data that looked like this. And what we conclude is there's a 100% chance that that child's pneumonia, so it's 99.9% chance it's caused by RSV. And that's what the data tells us, right? And here are all the most commonly occurring patterns for what we see in the children's noses. And you can see, here's the one we just looked at, and we're certain about that. But there are others where, based upon what we see, we just don't know what's in there. One, we have higher probability of some things than others. So this is an example, going back to my very beginning, of having a population of 5,000 children, 5,000 controls, by leveraging that data to be able to say what we can say best about a particular child using the model I just described. Okay, so let me go to another example. Here's a doctor who's sitting with his patient, and this man has been diagnosed with a Gleason 6 prostate cancer. That's a low-risk prostate cancer. And men in America who get diagnosed with that, 70% have their prostate removed or irradiated and end up being either incontinent or impotent and having significant medical discomfort and so forth, at the cost of about $30,000 for a prostatectomy. And we know that about 50% of those tumors are indolent. So we take out about 50,000 tumors a year in America, where when the pathology is done on the tumor, it's an entirely indolent tumor. By indolent, I mean that it would not have affected the man's life. He would have died long before that tumor did anything dangerous to him. So actually, we should have left those tumors where they were, right, to avoid the side effects of the treatment. So what's the underlying true state of health? It's what's the aggressiveness or indolence of the underlying tumor, right? What's the data? Well, the data we get on these men looks like this. So this is a man. These are his PSA repeated scores over time. And these are the indications that he had 1, 2, 3, 4, 5, 6 biopsies prior to having, at this moment when he's trying to make a decision. And each of the biopsies only found Gleason 6 pathology. They never found cells that were more aggressive than that. And so, he's sitting here deciding what to do. And then we have, that's this man's data. So here's the true state of the tumor. Here's all that data I just showed you. Right, and we have data like this at Hopkins on 1,500 men. Here's a random draw of 9 of them, right? And for these men, we actually got for a subset of them, we actually got the tumor out and we could get the full pathology, so we knew whether they were aggressive or indolent tumors. And here are the men that had aggressive tumors, right? And so now what the clinician has to do is look with this patient here at these data and try to then ask the question, try to refer the patient against the population, just the way we did in that screening example. Yep. And you have to ask the question, is he more like the red boxes or is he more like the not red boxes? Yep. And so that's what the algorithm does, and this man is estimated to have an 8% chance of having an aggressive tumor. 8%. So what we want to do is give to the patient and the doctor this picture that has all his data. This is where his PSA is likely to go. This is where his probability of having a positive Gleason 6 or higher, probability of Gleason 7 or higher. It would be plotted up here if he had one of those. At his next biopsy, if he has one, this is the chance he'll get a 7 or higher, and that's his chance of having an aggressive tumor. So now they can make a decision and decide what risks they want. Okay, one more, maybe one more example. So here's data from about 600 people, who had diagnosis of schizophrenia and joined the clinical trial. And this is their positive and negative symptoms of schizophrenia scale score over time from 0. This is only an 8-week trial. So we have about 600 men there, I think. And so that's my population. I want to do exactly this kind of thing, but this time what I want to do is there's actually, see that little thing happening up in the left corner? What I want to do is I want to say, where is this man headed, right? I'm sitting back here with his first observation. Where's his trajectory likely to go? So in order to do that, you have to know something about the joint distribution of all of the measurements. And in fact, what we've done is we have separated the positive and negative symptom scale into the negative symptoms and the positive symptoms and the general symptoms. These are just different questions in a 32-item questionnaire. I think this is 8, 8, and 16. But what I'm plotting here, just look at the negative symptoms, is a correlation that can go from -1 to 1. Forget the diagonals, those aren't interesting. Off the diagonals, that's the correlation between the baseline measure and the value you see a week later. Here's the value you see from the correlation between baseline and 2 weeks later, 4 weeks later, 6 weeks later, 8 weeks later. So these are all the pairwise correlations for the negative symptoms. Here are the positive symptoms with each other, and here's the correlations of the positive with the negative symptoms. Yeah? And here's the negative with the general up here. Are you with me? Sort of. Okay. Anyway, you look at, what do you see? Tell me what you see here. We're almost done, I promise.
Some hot spots, negative, positive.
I love people answer questions. Thank you. So you see, well, you see, where's the reddest stuff? Negative symptoms. We're on the diagonal. Negative has much more correlation with itself than positive does with itself than general does with itself, right? This is more red. What does that mean? In terms of negative symptoms are things like apathy, loss of appetite, things that are gone from your personality. Positive symptoms are like hallucinations, not good things, they're like hallucinations and wild suicidal thoughts and things that are added to your personality. So what can you tell me about things that are added to your personality versus things that are taken away from your personality? Which are more stable? Which tend to persist longer? The red ones, right? Red ones means correlated, strongly correlated over time, right? That's already down to about close to 0, right? So 8 weeks later, whatever your value for the positive was, it's going to be unpredictable. It's not going to be predictable where you're going to be 8 weeks later, but for negative, you're going to still have a strong prediction. Okay, so we combine this information. I'm interested now in this one man. Where is he headed? And so here's his first observation. So he was in the middle for negative. These are general symptoms. He was towards the low end for negative. That's good. And he was at the high end for positive. And this is based upon that population. This is where he's headed, right? This is what we can show him is what to be expecting. This is for men who are getting a particular treatment, right? So you're on this treatment. Let me show you where you're likely to go. Here's where people like you went when they got that treatment. And then the next time he comes in, well, we have new information, right? So he's gone down. So let me just see if I can, you can actually see there's the first predictions in light in the background. We've said, no, you're going to be better off than we thought. You're doing great for negative, and you seem to be doing better for positive as well, right? And the thing passes through. So this is an example of taking a population of people, of having fairly complex data, three numbers at each of many times, trying to understand the trajectory and using the population to inform the trajectory. This is a scleroderma with proteins I'm going to skip for all time. I just want to close by making a couple of comments. So if people like us are going to change medical practice, and we have an opportunity to do so because clinicians are sitting there now thinking to themselves, what does this information mean? It's getting too complicated. If we want to help them make better decisions, we've got to do a couple of things. So the first thing we have to do is we have to identify the unmet medical needs where the data are relevant to the decisions. So for example, half of active surveillance prostatectomies yield indolent tumors that shouldn't have been taken out. Yeah? You have to have a biomedical model. You have to understand what indolence and aggressive tumors, what's different, what are the predictors of the underlying state, what do we know about the genomics. You have to sort of build a biomedical model of the problem. You have to have a relevant data set, and this wrangle, I love this word wrangle, that you computer scientists use because that's, you feel like you're fighting with it all the time. You have to build a clinical database that's it's the population of people against whom we're going to refer an individual patient. You've got to build the tool using the kind of techniques I've described or something that you want to do that's different. And then you've got a tool that makes the predictions. You then have to decide how well that tool works. So you have to have a way you have to get it to where the patient and the doctor are sitting. So this little prostate app we did about a year ago, it's still not yet in the Epic system at Hopkins, and it's costing $300,000 to get a clinician to be able to see that thing when she or she's sitting with her patient. And so that system is just not where we're going in the future, but that's what it is today. And then you have to curate this. We get more patients into the system every day, right? And we're now doing this with the University of Washington, and we're maybe going to do it with Penn. You guys will join us. And we get more and more patients. We have to keep the model getting better and better. We have to curate the model if you're going to actually rely on it for clinical purposes. And then, I said there are 40,000 men who get their prostate out when they shouldn't. We should make this, and this tool will reduce that rate. We should make it available to everybody. So you got to scale it up. Some of the talks we heard this morning have a lot to say about that. And then the other thing is you got to figure out who's going to pay for this thing to be run over the long term, so that you can not only keep it going, yet make it better, but also make more versions of this. And that's the point here. Here's one little tool and a little application, and we have all of medicine to tile the clinic. Okay, so don't worry about this. I'm just going to close with my last slides. So the main idea is, once again, I hope I made clear what I meant when I said individual and population health are two sides of the same coin. The goal of data science is to be able to inform decisions made by individual clinicians and their patients with populations of data that are relevant to their decisions. The low-hanging fruit is to try to be more able to communicate what the person's health state is, rather than just showing them lots of noisy data. I showed you an example of a simple Bayesian network model that would allow you to build these kinds of tools fairly easily. And we have a software development project which is trying to make it so that clinicians can build these tools rather than just more people like us. Anyway, curation and all this. So I'll stop there. Thank you very much.